All right. Hi, everybody. Thanks for having me. It's nice to see some friendly faces in the audience. My name is Chris Elliott. I'm one of the urologists over at Valley Medical Center. Part of my task when I took the job at Valley Medical Center 3 years ago was reviving kind of the urology rehab clinic, which is a kind of a coordination between Katsuko Shem of physical medicine and rehabilitation and myself over in urology. So we have a half-day clinic once a week where she sees patients, I see patients. If I have questions that are rehab-related, she will answer them. She has urology questions about patients she's seeing, she'll ask me. It's actually been really nice because while I did urology training and I did complex urodynamics and fluid dynamics, I didn't see a ton of spinal cord injury patients during my training other than a lot of my time over at the VA with John Lavelle. So I've really gotten to know a lot about spinal cord injury in my time. I probably doubled or tripled my knowledge in the last several years, and I found it quite rewarding to work with a lot of the patients that I have. So the title of my talk tonight is what can a urologist offer to anyone with a spinal cord injury? And I hope the answer is something good. So briefly about myself, I grew up in Miami, Florida for a while, and then I moved to Orange County for a while, and then I moved to Columbus, Ohio. I then went to college at Miami of Ohio, went to medical school at Ohio State where I did a combined MD and PhD program. So I have a PhD in epidemiology, which I still use to this day as doing some research. I've actually done a little bit of spinal cord epidemiologic research in the last year with Dr. Shem's help, which has actually been really kind of fun to do. I then came out to California and did my urology residency at Stanford. So I moved out here in 2004, and I've been here the last 11 years in California. After 6 years of residency, I did a urology fellowship as well at Stanford with Craig Commodore and Chris Payne, who do a lot of incontinence type work. I also spent half my time with the gynecologist at Stanford, so I learned a lot of female prolapse and incontinence work. And along the way, I saw many patients with MS, Parkinson's, spinal cord injury who I got to work with. And I spent a little time over at the VA with John Lavelle as well, who probably many of you know or have heard about. So currently I'm with the Division of Urology at Valley Medical Center. I have a joint appointment at Stanford as well. My interests are not only seeing patients with spinal cord injury, but also males and females with incontinence and prolapse and helping them through those issues. It's amazing how much there is. There's never a shortage of business, especially at Valley. And about 15–20% of my time at Valley is actually just doing general urology. People with stones, people with BPH, big prostates, doing TURPs from time to time. So I get to do a little bit of everything. So to spinal cord injury, which we're all here to talk about, the scope is there's only about 12,000 spinal cord injuries per year in the United States, not a ton. So when you look at it in terms of many diseases in the United States, it's actually a very small, limited scope, and it's kind of a little bit underfunded and a little bit misunderstood by a lot of people that are out there. So I kind of feel like a lot of times I'm what people turn to when they don't have answers, and I'm often shocked at how little is done in the community to support my patients when they aren't seeing me. Of these 12% are unable to volitionally void after their spinal cord injury, which is a fairly substantial number. And I'd posit that even the other 25% who are voiding on their own, it's not quite the same a lot of times. And a lot of times, even people that are peeing on their own, they still come see me because something's not quite right. So the overall goals of the bladder, if you just try to figure out what all of us are trying to do, whether we have a spinal cord injury or when we void, and the bladder doesn't squeeze unless we want it to. So you want to empty at socially opportune times, and you want your bladder to squeeze, and you want your urethra to relax, and they need to be in a coordinated fashion. And it's kind of a survival of the fittest, because if you're leaking urine all the time, the lion's going to find you and eat you, and then you can't procreate and pass on your genes. I always thought that was a simple way of thinking about it. So coordinated voiding requires not only our brain, but our spinal cord. And if you go right here in your brain stem, this is the area of the brain that kind of coordinates everything. When the bladder wants to squeeze, it takes the signals and goes, yes, the bladder wants to squeeze. The forebrain tells it, sure, this is a good time. I'm not in the middle of a talk with, 15 people in a room. I'm in the bathroom. This is time when it's supposed to be. But then this part coordinates, and it says bladder can squeeze, and it makes the urethra relax at the same time. The problem is when you have a spinal cord injury, some of that gets disrupted, and it gets disrupted to varying degrees. It really kind of depends on what type of injury you have. There's incomplete injuries, there's complete injuries, and what you see kind of depends on what's left. But oftentimes with a spinal cord injury, there's a lack of coordination. So the bladder may still kind of squeeze on its own, but it may not be under your permission. But even if it does squeeze, the urethra doesn't always relax. And this can create a very dangerous situation for people with spinal cord injury, something called detrusor sphincter dyssynergia. Back in the 50s, 60s, 70s, this would be detrusor sphincter dyssynergia. Your bladder squeezing, but you're not safe, and this can have deleterious effects on the kidneys. So what you see here in this picture is actually the bladder trying to squeeze, but all the urine, which is black, is getting stuck in the urethra down below. And you're actually getting reflux up in the kidney. You see that line kind of heading up over on the left side. That's urine being sent up into the kidneys. It's not good. This is a bad bladder, and this is why people used to not do so well. Because of this, inappropriate bladder management before people really got a good handle on it would lead to renal failure in up to 25% of people with spinal cord injury. So prior to the 1970s, 25% of people with spinal cord injury died of renal failure. It wasn't UTIs, it wasn't anything else, it was renal failure, which is almost 0% these days now that we actually know what's going on and we have good understanding of what's going on. But inappropriate bladder management can also lead to incontinence, and it can lead to decubitus ulcers. It can just lead to the bothersome part of incontinence. It can lead to autonomic dysreflexia in the people that are T6 or above who are prone to this, and can lead to rapid rises in blood pressure, which are not only kind of annoying for people that have it, but can lead to stroke in rare cases if not taken care of. Death due to low blood pressure, just bad infections, and you can also get kidney and bladder stones just due to inappropriate management. So my goal is to keep all of these really horrible things from happening to people, and honestly, it's really not that hard most of the time to take care of most of these things. So my number one job is to protect the kidneys. Like I told you, 25% of people used to die of you can't void. Pick an appropriate bladder management strategy that meets their goals and overall kind of what they want out of life and how much time they're willing to devote to their bladder. And also to troubleshoot any problems that come across. If they have incontinence, my job is to make that incontinence go away. They have infections all the time, my job is to figure out why that's happening and take it away. If they're having trouble with catheterization, find a solution for that patient. And if they have kidney and bladder stones, well, let's get rid of those and let's try to keep them from happening in the future, or at least minimize the bother to the patient and the number of surgical procedures you need down the road. So problems for patients with SCI, number one is, do you cath or do you have an indwelling tube, like a Foley or a suprapubic tube? And that can be very dependent on what is your hand function, what is your body habitus, are you horribly overweight and can't find the urethra, and gender. Males, it's a lot simpler often to pull out your penis and catheterize. Females, they don't have that luxury. It can be actually quite difficult and quite time-consuming, even if they're good at it. So these can all take into account what people choose to do. And then leaking has a huge impact on a patient's life, whether it's stress incontinence, leakage with transfers and things like that, or overactive bladder that's just leaking randomly or at very low volumes, which can be bothersome to the patient. So, as again, key to options are obviously hand function. I think it's one of the most important things that patients have, whether you have hand function or not. It has a huge change on what I will suggest to a patient. Because without hand function, you really can't do intermittent cath on your own. You might have someone else who's able to help you with it, but you won't be able to do it on your own. And it makes you dependent on others. If you don't have good enough hand function, you have to have someone there with you all the time that's able to help you. It's really not a good way to live life, being totally dependent on others all the time. I try to give patients a little more freedom in their life if they choose. There are a lot of people that have the means to have someone there all the time, but most of my patients don't. And I find that quite striking, and I feel that people don't always think about that ahead of time when they get discharged from rehab. So let's go through all the bladder management options and what's good, what's bad, and what is kind of so-so. Leaking, just leaking into either a condom catheter or into a diaper. I don't like it. Here's actually a patient I just saw. In this day and age, it kills me that this happens. But this is a guy who had been leaking for 7 years straight into a diaper because it wasn't convenient, and he didn't really have good follow-up by the doctors that were taking care of him. They didn't realize the downstream sequela of this. So this is his bladder on recent imaging. As you can see, it doesn't look very normal. It looks kind of like a clown with a hat on it. We call this a Christmas tree bladder. But what had happened is, because he had such high pressures in his bladder for 7 years straight, he had essentially lost 50% of his kidney function. Luckily, I came along and was able to figure this out for him, that it wasn't working out. But again, he's already lost 50% of his kidney function just because of mismanagement. And this is the picture of a bad bladder. And this is why prior to the 1970s, 25% of people with spinal cord injury died of renal failure. They let everyone leak into diapers or condom caths. That's just the way they managed. They didn't realize that you should be cathing people or putting indwelling tubes. Everyone thought that bred infections, and they didn't want that, so they just let them leak, not realizing that, in fact, they were actually doing worse for their patients. So let's just agree that leaking into a diaper or a condom cath is probably not the best option. There are some people with sphincterotomies, and I'll go to that later. But just leaking de novo is probably not safe. In rare cases it is, but usually not. Urethral Foley's. Long-term urethral Foley, catheter through the urethra, is not a good option. Here's a man who's had a catheter in for 5 years. It's eroded through his penis. If you look, it's just split the penis in half. It'd be easier for me just to take a knife and cut it in half, but this is what happens over time. It's something that shouldn't happen. In a female, it's even worse because it's going to erode through your urethra completely, and females have very short urethras. So pretty soon it's eroded through your sphincter, it's eroded through your bladder neck, and you're gravitationally incontinent. These are major reconstructive fixes. I see one of these a year that I have to go fix, and it always breaks my heart when I have to go fix it. It's an interesting case, but it shouldn't happen. So I would say long-term urethral catheters are not something anyone should have. Suprapubic tubes, I think they're great for certain people. There's no urethral erosion. You have use of your penis or vagina. You don't have a big tube in there all the time. But it does have a couple downsides. But it's also easy for caregivers to take care of. It's a lot simpler than a Foley a lot of times. And the one thing you should know is Foley, SP tube, there's no difference in UTIs. There's this common misconception that if you take the catheter out of the urethra, you do a suprapubic, all my patients say, oh, well, I'll have less infection. That's not true. It's the same. You have a tube, bacteria crawl around the tube, pretty soon your bladder's colonized. That doesn't mean you have a problem. That just means you have bacteria in your bladder. But certainly there's no reduction in urinary tract infections. So if you look at the long-term problems with suprapubics, there are some, and I'm sure people in this room could somewhat speak to this. Recurrent catheter blockage, bladder stones, they're common. They're up to 30 to 40% of people have these because you have something in your bladder all the time. You've got this balloon, and it just sits there, and the urine kind of encrusts over time. Crystals encrust, and little pieces can break off, and then they're sitting in your bladder, and they're not draining out, and they get bigger and bigger and bigger. I saw a guy today. He's had an SP tube for 3 years. He now has 2 3-centimeter stones in his bladder that I'm going to have to remove. It's not hard to do. It's, and it's a necessary evil. He doesn't have good hand function. But it's one of those things that maybe I told him we need to be a little more vigilant in the future. And let's get these things out when they're, half a centimeter and just pull them out in the office with a basket. Let's not have to go to the operating room and deal with this in the future. And you can see infections are quite common, 40% of people at 5 years. Every single one of these people had bacteria in their urine, and that's just part of life. Once you have an indwelling tube all the time, you're always going to have bacteria in your bladder. Doesn't mean you're sick. I have bacteria in my ear all the time. Doesn't mean I have an earache all the time. There's a symbiosis there that can be. It does cause problems from time to time, but if you go into a doctor's office and it's just a well check and they check your urine even though you feel 100%, you're going to be told you have a UTI every single time unless they understand that you have a chronic indwelling tube, and that's just part of your life. You don't treat them unless they have symptoms. This is another group that, same thing, bladder stones, 65% in this group, even higher than the other group at 40%, symptomatic UTI, 12%. All to say that suprapubic tubes, while they can be great for people, are not without their own problems. So suprapubic tubes are okay. Credé voiding, reflex voiding, unless I do your urodynamics and I say it's okay, you have coordinated voiding, I'll accept it. I don't want you doing this. But I'm willing to entertain the thought for people. I don't love it. Condom casts, that's just a way of leaking. Instead of leaking into a diaper, you leak into a condom cast. I don't love it unless I've done your urodynamic study and shown that you are safe to do this. It's the rare person that's actually safe. Condom casts just mask bigger problems, and huge problems like the guy I showed you before can result as just a guy with a condom cast. CIC. This is kind of the gold standard for most people who are unable to void after spinal cord injury, but it's not for everyone. Like I said, if you don't have good hand function, it's going to be hard to do CIC. But CIC, you wouldn't believe, but it was only discovered in 1972. There's a guy named Jack Lapides up at Michigan. He's actually famous for this discovery. You would think, what a silly thing to be famous for. It's so simple. But up until that time, everyone thought if you catheterize all the time, you're going to get horrible infections. He had a lady who absolutely refused other things being done and wanted to catheterize. She learned to do it. She did fantastic. He tried it on 7 or 8 more people. They all did fantastic. And he wrote this seminal paper in 1972 that changed the way everything was done for people with spinal cord injury. So what's the advantage of CIC? Well, you don't have a tube in your bladder all the time, so your risk of bladder stones goes down tremendously. This is a group that followed people out long term. You can see with not having an indwelling tube, your risk of bladder stone goes down or is tremendously less than people with indwelling tubes. SP tube fully, you have about the same risk. So what's the problem with CIC? Well, you don't have the motor strength like I've suggested. It's maybe not the best option for you. It can be difficult for females in terms of access. Body habitus can make it difficult. The more overweight you are, especially when you're female, the more difficult it can become. Yes? Oh, I'm sorry. Intermittent catheterization. Clean intermittent catheterization. Sorry, I get lost in urology speak from time to time. The question was, what does CIC stand for? And it's intermittent cath. I often forget to explain that. And the other problem with intermittent cath is you can leak in between catheterizations, which can be very bothersome, especially socially or from a cleanliness standpoint for patients. So obviously CIC or intermittent cath is not for everyone. So, and this is kind of shown by national data. So this is a group at Michigan that looked at how many people on intermittent cath stay on intermittent cath at 5 years, and they found that only 50% of people who are discharged from rehab on intermittent cath stay on it for 5 years. And a lot of this is attributable to poor hand function or being female. We've just done a recent study here at Valley, which will probably be published in the next year. Those are the 2 main risk factors, but obvious to say, not everyone stays on intermittent cath. And like I said, one of the keys, besides having good hand function and being able to do it, is not leaking in between. I see so many patients that said, yeah, I did intermittent cath for a while, but I was leaking in between, nobody could fix it, so I changed to something else. And I feel bad because I tell people who leak in between catheterizations, if you cath, there is no way that I won't be able to get you dry if you give me some time. We may have to try several things, but there is no way that I can't get you dry. It's very easy. So how do we deal with leakage in between catheterizations? There's medications. Everybody knows the anticholinergics, oxybutynin, Detrol, things like that. There's also, in the last 2 or 3 years, a new class of medications on the market. They're called beta-3 agonists. They work on a different receptor in the bladder, but they work very similar to anticholinergics. The good thing about these meds is they don't have the same side effect profile that a lot of them, the anticholinergics do. Dry mouth, dry eyes, constipation. They don't have those, so a lot of people love them. The problem is they're not covered by a lot of insurances and they're very expensive. It's about $300 for about a 30-day supply. However, over time, these will become generic and they are going to become mainstream for everyone, not just those with insurance plans that will cover them or have a lot of extra money to spend out of their pockets. Besides medications, when medications fail, what else do we have to offer? We have Botox. Botox is relatively new within the last 15 years. but it can work substantially well, and I'll go into detail how Botox works. It's not just for wrinkles for movie stars anymore. It's for spinal cord injury patients as well. So Botox was introduced actually in the year 2000. There was a smart lady in Switzerland named Bridget Schurch who realized that people were using it for not only striated muscle, like for muscles that are voluntary movement, but also for muscles of like the esophagus, that people were having spasms of the esophagus. They injected it in their esophagus and the spasms went away. Made it real convenient for people who are having trouble swallowing food. And this smart lady realized, you know, the bladder is a smooth muscle. Why shouldn't it work for my population of patients with spinal cord injury who are leaking in between? So she took a group of about 19 people and she injected it into their bladders and did a very good prospective study and got it published in New England Journal of Medicine. So she became kind of famous for this. But she took 19 people and showed that she could essentially double their bladder capacity at 6 weeks and increase it over 50% even at 6 months out from the injection. Again, doubled their capacity, and at 6 weeks, 17 of 19 were completely continent, and this was a group of patients who leaked a lot. So this was like a huge thing to get them completely continent. And even at 6 months, 65% were still doing quite well and completely continent. My experience is it generally lasts for about 4 to 9 months, depending on the patient and depending how bad their bladder is. But if you combine this with anticholinergic medications, I can get the majority of my patients dry without even having to do a major operation. This can be done in the clinic. How's it done? I put a tiny scope in your bladder while you're awake. You're sitting in my office. You're watching it on a television screen. I take a little needle through my scope, and in 20 different places, I inject Botox. This is kind of what it looks like. The bleeding is very minimal. It looks a little bit scary on this slide. I promise you it's not. It's simple to do. Takes me about 10 minutes. So if Botox doesn't work, what else do we have? Well, we have kind of the old standby, surgery. This is a surgery, augmentation cystoplasty. I take a piece of your intestine. I take about 20 centimeters. I detubularize it, so I cut it across and I make it into a big sheet and I form it into kind of like a yarmulke or a hat that will fit on the bladder. I cut the bladder in half. That will decrease the bladder's ability to squeeze all the time without its own, because you're kind of taking the muscle away from other muscles, so it can't make the connections. I'm adding this big hat on top of your bladder, and this will almost unequivocally get you dry. 99% success rate. The only failures are people I don't take enough bowel to do it with. So how do I think about things? Number one is hand function. I've made this very clear. When I see a patient for the first time, the first thing I do is I ask them, I shake their hand, and if their hands aren't very good, I ask them to try to hold a pencil. If they can't hold a pencil, I don't know how they're going to cath on their own. So like I said, if you can't do CIC, you're dependent on others. I don't like people being completely dependent on others, especially for a bodily function that needs dealt with every 3 to 4 hours during the day. So even if you have adequate hand function, how hard is it for you to perform intermittent catheterization? Think about a female paraplegic. Most of them can't catheterize in their chair. Some of them can. They're pretty amazing. They have to get out of the chair. They have to lay down on bed. They have to take down their clothes, pass the catheter, empty their bladder, get back dressed, get back in their chair. It can take up to 15, 20 minutes. Imagine a function that you have to do at least 5 to 6 times a day where it takes you 20 minutes. That's 2 hours a day minimum. It's a huge, huge deal. So they did a study up at UC Davis up in Sacramento, and they just took quadriplegics who could not catheterize themselves, but their caregivers were doing it for them. So they had someone who was completely able-bodied trying to help these people. CIC was taking them an average of 27 minutes. They then did something kind of novel. They gave them instead of catheterizing from below and having to take down pants and get out of their chair, they gave them a catheterizable stoma. So a little tube that connects from their bladder up to their belly button. Then all they have to do, lift up their shirt in a chair, place the catheter, drain. Took them 8 minutes. So they saved them 19 minutes, 6 times a day. It's 2 hours a day they saved them with surgery. And this is what it looks like. They place a little catheter through their belly button. You don't need perfect hand function to do this. You just need one good hand. That's the difference. You need 2 good hands really to catheterize from below. You need 1 good hand to catheterize from above. So I see a lot of patients with only 1 good hand that are having trouble cathing. We can make it better by doing this procedure, and I'll show you how it works in a second. This is how it looks from the outside. Here's a 25-year-old guy with only 1 good hand who I just did in July. He came back for his follow-up a couple weeks ago. This is what it looks like. He's got this little catheterizable stoma. He just lifts up his shirt, he catheterizes. If I was really pushing my luck, I would have brought it to his belly button, but he didn't really care, and I was afraid I was going to stretch my tube a little too much and cut off his blood supply. So given that he had this perfect little appendix that I was using, I didn't really want to mess it up. So how do we make these catheterizable stomas? Like I said, you can take appendix. So everyone thinks the appendix is useless. Well, to a urologist, it's not. It's a perfect tube sometimes. We take it off the large bowel. We take it with its blood supply, we put it into the bladder, and then we bring it up to the skin. Depending on how long the appendix is and how the caliber of it, sometimes they're not usable. They're these tiny little things that a catheter is not going to go through. But usually they're fairly robust, and if they're long enough and I can stretch them somewhere, I'm going to use it. So what happens if you've already had your appendix out? Well, I still have your small bowel, and I can use fairly simple techniques to cut the bowel lengthwise and roll it in another direction and make a nice little tube out of it. There's some super smart guys who are at Indiana that realized if you take a slightly longer piece of bowel and you configure it in this weird configuration, you can make this spiral, and you can make an even longer tube with it. So using a 4-centimeter segment of bowel, I can make something that's about 15 centimeters, and that can reach almost anywhere. So even if I go in to do your surgery and I'm planning on using your appendix and your appendix is terrible, I can still do stuff. I'm never at a loss of things to use because everybody has small bowel to use. So what happens when I do one of these? Generally, I want to make your bladder bigger as well because it decreases your chance of leaking. So I'm already there. I'm already messing with your bowels. Why not fix everything at once? So usually when I do a catheterizable stoma, I make your bladder bigger as well with an augment at the same time. It's a very rare patient. I won't do it. I'm there. I've got the materials. I don't want to go back a second time. Get it right the first time. That's all the patient really wants. They don't care how you do it. You can also use the large intestine, and you can use a different segment of bowel, which actually has its own little continence mechanism to do this as well. So there are people out there with what's called ileocecal cystoplasties, and they catheterize through these. I've done these too. So again, I'm never at a loss for things to do and tricks to have when I do these. So what if you're unable to do intermittent cath? So no matter what, whether I make you a cath stoma or not, your hand function just isn't good enough to do it. Well, you might have a caregiver who's able to do it all the time, or maybe we should do something else. Again, I already told you I don't like urethral catheters. They cause erosion, they destroy things over time. But we could do an SP tube. SP tubes work quite well. They're simple procedures. They take 30 minutes in the operating room. It takes me, seriously, 10 minutes of operating time to place. Sphincterotomies, because this used to be super popular, and I'm sure everyone knows someone with a sphincterotomy. A suprapubic tube. Sorry, I shouldn't have used all these abbreviations. So the question is, what is an SPT? An SPT is a suprapubic tube. Again, sorry about all the abbreviations. So let's talk about sphincterotomies real quick. These are operations that used to be done a lot. What the urologist did was put a scope in, and then they resected out the entire bladder neck, prostate, and the sphincter muscle, which is just distal to the prostate. So they would just make a big giant hole, and everything that would keep a patient continent was ripped apart and destroyed, but they would then leak into a condom catheter. They couldn't do this obviously on women because women can't wear a condom catheter. They don't have a penis. So this is kind of what it would look like, and as you can see, we just make a giant defect in the tissue. Problem with this is groups started studying these, and they had about a 50% failure rate at 5 years. That means a lot of people needed repeat surgery, and I've never seen someone who needed a repeat sphincterotomy surgery that didn't have problems that repeated themselves down the road. Certain people are prone to scarring their urethra. Those people that fail, it'll just keep happening. There's also people whose bladders just kind of poop out over time. They become these big floppy things, and they just fill, and they don't really empty well at all. So even if they're wide open from their sphincterotomy, they're not draining well, and they get recurrent infections and all sorts of problems. It's a nightmare to try to fix because even if I put a suprapubic tube in afterwards, you're still leaking from below and you're leaking from above. You now have two bags. If I try to close off your bladder neck, it's an incredibly bloody surgery. It can be done, but it's not my favorite thing to do. So two groups have studied this. They've noticed 50 to 60% failure rates over time. So this is not something I readily offer to patients, though in the past it was quite popular to be. There are certain people out there who do remarkably well with this operation, but I tend to see the people nowadays who have failed this operation, and it's not my favorite thing to deal with because there's really no good answers a lot of times. And part of the problem is this is irreversible. I can't undo removing all sorts of anatomic things that someone gave us once upon a time when we were developing in our mother's uterus. So again, poor hand function, a lot of times I'll think of suprapubic tubes. There are certain people out there, though, that form bladder stones at rapid rates, and suprapubic tubes, they kind of get tired of it over time, and we start talking about other things. Those are ileovesicostomy. Let me explain what that is, because it's a big word. Basically, I take a small piece of intestine, I hook it up to your bladder, and then I hook it up to your skin, and you wear a bag over your skin. What you have is a little stoma, and it attaches to your bladder, and I put a little bag over it, and the bag needs to be changed every 2 days, and it drains into something else. The good thing about this is you don't have an indwelling tube, so your risk of stones decreases dramatically. The bad thing is you need an open operation to do it, and a lot of people, they have the choice between a suprapubic tube and an ileovesicostomy. Most people are going to pick a suprapubic tube because it's a lot simpler and the risk of surgery is a lot less.
How big is the bag?
It's about the size of a colostomy bag. It's a good question. The question was, what's the size of the bag that you fit over it? It's basically a colostomy bag, and it fills with urine. But we can hook that colostomy bag or urostomy bag up to another tube. You can wear it like a leg bag, like you would wear with a suprapubic tube. So you can get quite a bit of, you can hold 600, 700, 800 cc's in the two bags combined. The other thing we do in rare cases is do an ileal conduit, and that is where we abandon the bladder altogether. We take the tubes that drain the kidneys, and we hook them up to a small piece of intestine, and then you have the same stoma and wear a bag over it. As you can see from my prior slide, this is kind of a thing of last resort I do. I don't really like to mess with people's ureters that drain the kidney. In rare cases, they can have some scar tissue develop, and you can slowly injure the kidney. I don't love to do this, but we do it sometimes. I've done it in people who've had horrible, horrible bladder catastrophes from having tubes in for too long and have major problems. Sometimes you just have to abandon ship. So other considerations, even if we have your bladder perfectly under control, certain people still leak, and these are the people that leak with transfer. So these are people who, in addition to having maybe a bladder that doesn't work perfectly because of their spinal cord injury, they have a weak sphincter. Typically, it's people with L-spine and sacral spine injury, so lumbar spine or sacral spine. But it can be anyone, because not everyone's bladder and sphincter reads the book when they have their injury. They sometimes act a little different than they should. So if the sphincter is weak, we have ways of fixing this too. We have injections, so movie stars get injections in their lips to make them big. Sometimes I do injections in people's sphincters to make them tighter. We usually use bulking agents, either collagen or things like collagen to do this. This is pretty simple. I take a scope, I put a little needle through my scope, I find the sphincter, and I inject the bulking material, and it, in front of my eyes, gets bigger. And as long as it all stays in place where it's supposed to, it works quite well. It's usually a short-term fix. It generally only works for a year, 2 years at most, and people it really works in. But for some people, that's good enough, and they just come back and see me once a year, twice a year, once every 2 years, and get a repeat injection. And it can work great. We can also do slings. So we do slings all the time for normal females with stress incontinence. We can also do it for people with spinal cord injury who have stress incontinence. Leakage with transfers, leakage with coughing, leakage with sneezing, leaking with picking up heavy objects. And basically you just put a piece of either mesh or the patient's own fascia. So generally we take it either from their abdominal wall or from the side of their leg, and we can make it as tight as we want and stop their leakage. Works quite well. Typically in people with spinal cord injury, I like to use their own tissue because I can pull it a little bit tighter, and you can't do that with mesh. You don't want to pull mesh tight. It will erode through tissue over time. But the patient's own tissue usually doesn't harm their own tissue. It kind of forms this big scar-like area around their urethra, and they actually do quite well. Males have the same problems. We can put a male sling in. We do this for people after radical prostatectomy for cancer who have leakage. We can do it with men with spinal cord injury who leak with transfers, coughing, sneezing. It's a pretty simple surgery in a day. The female surgery, they go home the very same day or the very next day after their surgery. It's very simple surgery for me. Maybe not for all of you sitting here. The last thing we have is what's called the artificial urinary sphincter. And this is essentially a cuff that fits around the urethra. Typically do it in men. We do it rarely in women, but not very often. Very, very rarely in women. But we often will do it in men. We put a little cuff around the urethra. It's a plastic cuff. It fills with water. When it's full, it closes down on the urethra. You don't leak. When you want to pee, you pump it up, it opens, and you can either catheterize or remove all your urine. Works quite well. These do have some complications down the road of mechanical failure, like any mechanical device. Usually fairly easy to fix, though. So it does take repeat surgery generally to fix them. So another subject, bladder cancer in those with spinal cord injury. It's reported to be increased in those that catheterize or those that have indwelling tubes all the time. People ask about it all the time. Some have even suggested that all urologists should routinely screen their patients once a year to make sure they don't have a bladder cancer. Kind of falling out of favor, and I'll explain why. There's been multiple studies that have looked at people over time who have tried to screen their patients once a year with cystoscopy for bladder tumors. The problem is they never find tumors because it's such a rare disease. And for screening tests to be useful, the screening test has to be good, and the disease has to be very prevalent. The rate of bladder cancer in people with spinal cord injury or those who don't have a spinal cord injury is incredibly rare in both groups. The conclusions in 2003 were this is not a good screening test based on this trial. People have done prospective studies where they followed people out ahead of time and they followed them very closely and they looked at high risk groups. People who had tubes in for a long time, who were smokers. They didn't find anyone. They did 156 cystoscopies in these 60 people over 6 years. They found nothing during screening, despite taking biopsies on every single group. However, one patient did develop cancer 5 months after a normal routine cystoscopy. It solidifies in my mind it just doesn't work. I tell people if you have blood in your urine, I should look in your bladder, because that could be a sign. I don't do it routinely. But for anyone that wants to know why I don't want to do it, the evidence isn't there. And there was actually a very recent editorial in Journal of Urology where another Elliott, Sean Elliott, wrote a very, very nice description of why it's just kind of a useless endeavor. It just doesn't work. We have all the best intentions, it just doesn't work. It's too rare of a disease. So another note, UTIs. I have lots of patients that want to come and discuss their UTIs with me. It's a hard one for me because most people are using catheters, either indwelling catheters or intermittent catheterization. The rate of bacteria in the bladder at any time in anyone that uses either an indwelling catheter or catheterizes intermittently is about 100% of the time. If I just take a specimen, I'm going to find bacteria. Does that mean you have an infection? No. And if you feel great and a doctor takes a urine, they could diagnose a UTI. I have so many patients that, I mean, you can have your head chopped off, go to the emergency room, instead of sewing your head back on, they're going to diagnose you with a UTI every single time, no matter what your complaint is. It drives me crazy, but I cannot explain it to all the emergency room doctors and all the primary care doctors in the world. I can only try to educate my patients. Don't get treated for a urinary tract infection unless you have new onset leakage that doesn't seem right. If you start to have blood, sure, think about that. If you start to have new onset leakage, sure, that's a reason. If you have a fever, that's a good reason to probably consider you might have a UTI, but a urinary tract infection. But don't let people diagnose you with a urinary tract infection if you feel fine and there's nothing wrong with you. Please, please, please. Because the problem is I have so many patients that are getting treated all the time with needless antibiotics, and then they actually do get sick. And then I have very few antibiotic choices because they're resistant to half the stuff that we should be giving them. It's a big problem in this country, antibiotic resistance of the bugs that we are trying to treat, and it's only going to get worse in the coming years. I shudder to think what's going to happen in 30, 40 years down the road. If we don't come up with some new antibiotics in the pipeline, and there have been virtually none in the last 15 years, we're going to all be in real trouble. My spinal cord injury patients, I think, most of all. So, in sum, this is how I think about people. If you have good hand function, you should probably be doing intermittent cath unless you can void normally, and I prove to you you can void normally. If you're leaking, we have meds. If that doesn't work, we have Botox. If that doesn't work, I have surgery. I can get you dry. Don't worry about it. It'll happen. If you don't have good hand function, you get a suprapubic tube, you can get an incontinent ileal vesicostomy where you wear a bag over it, or you can get an ileal conduit. I don't do too many of the latter two, the ileal vesicostomies or ileal conduits, but we can if the patient is right and the reason is right. I don't really like condom catheters at all times unless you've had a sphincterotomy and I prove that your sphincterotomy is safe. Condom caths just because are usually bad news. They can mask a lot of bad things that are going on. Sphincterotomies, I don't typically do these. You would have to twist my arm and really convince me it's the right thing for you before I do it. I think it's more of a historic operation, and I think as the years go on in the future, I think that's going to continue to be the case. But there are a lot of people with functioning sphincterotomies, and if they work for you and they work great, that's fine. But when they fail 50% of the time and I'm left with very few options that are good afterwards, I don't really like those odds when I have better things to offer people. Long-term Foleys I hate. They create massive amounts of damage, and I have to go back and try to fix all that damage after the fact. I can do it, but it shouldn't have happened in the first place. We should have given you something different. Things I like. Yearly renal bladder ultrasounds. There's no radiation involved. I can keep an eye on your kidneys. If we're having issues with hydronephrosis or suggesting that bladder pressures aren't good and that your kidneys are slowly failing, we'll catch it before it's a big problem. If you have a stone, it'll catch a big stone. Also take a look at your bladder. hard, come see me. The good news about most of these things, and we're talking about insurance issues right now. The good thing about most of these things is they won't kill you. They're a nuisance. But I don't have perfect answers for you. I'm sorry. I'm happy to see you.
I always have UTI. For some reason, I'm more sensible to those. So one of my biggest dilemmas dealing with my accident is everything I know about the UTI is because I have the source on the internet or just on the hard way.
So the question is, a gentleman's telling me that he has a lot of UTIs and kind of no one's really helping him deal through those. I often say, don't always think it's a UTI. If you're just having leakage and that's the main symptom, a lot of times it's just a bad bladder. And like I said, everyone's got bacteria in their urine, so it's easy to blame a UTI. If it only happens every 3 or 4 months, I might say it's a UTI causing it. If it's every month and you're just getting a different course of antibiotics every month, oftentimes it's an overactive bladder that's irrespective of a UTI. And if we just do more medicine for your bladder or we do Botox injections or something else, you'll magically find a lot of times the UTIs go away because it really wasn't a UTI in the first place. It was something else. Just my spiel, but it's something I do believe in. And I do see at least once a month someone comes to see me for recurrent UTIs and their symptom is leakage. And we do studies and we find out it's really not UTIs, it's something else. And we treat the source and all their problems go away. It's not universal. I do have patients that are just very prone to UTIs, and there are certain people who are. And I don't want to poo-poo that idea because there are people with that problem. But many times it's not as simple as we'd like to believe.
What part do you become concerned about how many you get per year?
Okay. So the question is, when should you be concerned about how many UTIs you have a year? I tell all my patients who either have an indwelling catheter or do intermittent cath, I expect them to get at least 1 to 2 UTIs per year. That's just the price of business for having what you have. Once you start to have more than one every 3 months, then I start to get concerned that something's going on, and I will probably do a workup to figure out, number 1, is it a true infection? Number 2, is there a source of that infection? And number 3, if there is no source and there's no other cause, it's not, your bladder just being overactive and us misunderstanding the signals, then we'll try to figure something out. Either antibiotics in the bladder once a night with some irrigation, something that isn't going to harm you long term, but that might actually help the problem. And we see how it goes. Sometimes it works, sometimes it doesn't. There are occasional patients I just have no good answers for, and we just have to treat it as it comes. But there are a lot of patients we can find a way to make things better. I would say probably 75 to 90% of the time I can find a good solution for that patient.
So how do you define UTI? Asymptomatic?
Yeah.
This has cloudy urine,
So yeah, how do I define a UTI? Cloudy urine just means you're probably not drinking enough, and I tell you to drink more, and it usually will go away. Doesn't always. It could mean there's a bunch of bacteria in your bladder, but if you're not having fevers, you're not having leakage, you're not having some other symptom, I say don't treat it. Drink more fluid. It will probably go away on its own through just good flushing of the system. That's how a lot of women can treat their infections, not with antibiotics, just by drinking more fluid. The whole thing about cranberry juice gets rid of a urinary tract infection. It's not because it's the cranberry juice, it's because they're drinking a lot of fluid and they're just flushing the system. That's the body's main defense of getting rid of infections in the bladder. So I tell people, if they just find bacteria in your bladder and you're not having any symptoms, smelly urine is not a symptom, cloudy urine is not a symptom. Fevers, incontinence, some other major problem, that can be a sign of a UTI. A lot of people may disagree with me, but I think that as a hard and fast rule, that works for most people.
I agree. Most of the time, my urine infects, and it is cloudy. But if I get a fever, I know that I got an infection.
Yep. I think the other thing is when you have a fever, make sure you don't have a chronic cough or pneumonia or something else that might be causing it.
I always wait a day.
Okay.
When I get it. If I get worse, then I know I got it.
Yep.
Just
And so yeah, I agree that, you know, making sure that's what you have and making sure just flushing the system isn't going to work. But there are some people that get sick very quickly, and those people, they know who they are. And once I get to know you well enough, I generally believe you. But I'm a skeptic in life, and so.
You take a sample and wait 3 days and give you medicine. By 3 days, you're almost dead.
Yeah, the statement was, you know, waiting for cultures to come back before you treat sometimes takes 3 days. I often will start people on empiric therapy, especially people that kind of know what's going on, and I've gotten to know them well enough to trust their instincts. It's hard when you first meet somebody who comes to you for recurrent UTIs because you kind of have to build a rapport, and I have to get to the point where I say, okay, this person's not crazy, they're not doing it for all the wrong reasons, they're not just doing it because there's an odor, they're doing it for legitimate reasons. And I'm very sensitive to the idea of not over-treating people for urinary tract infections because the majority of the time, a urinary tract infection will not kill you. But there are exceptions to the rule, and the more I work at Valley, the more I see exceptions, and I get a little softer in my stance every year. Yes, sir.
When I get UTI, that makes me terribly sick.
Mm-hmm.
I feel like I'm gonna die.
Yeah, so the statement was the patient that feels horribly sick, like he's going to die with UTI. That's a good reason generally to treat you. I mean, you don't have to have a fever and be on your deathbed or need to go to the emergency room. There are certain people that just say, I know it, I feel awful. And I don't really have a way of arguing with that.
So that means, do you recommend you go right away when I start being sick? Do they do that or not?
I recommend, so the question is, what's the recommendation if you just feel horrible? You don't have a fever, you're not leaking. What do you do if you just feel crummy? Two things. I like people, I don't mind writing them for empiric antibiotics, but I also want to send a culture before you start the antibiotics, because what if I guess wrong? What if I guess an antibiotic and I pick an antibiotic that isn't working for you? I'd really like to know that in another 2 or 3 days. So if you're not getting better, I know why. I'd also like to know if I have you on the right antibiotics and you're not getting better, maybe that means you dropped a stone or something that isn't going to get better with just antibiotics. I have a number of patients who've shown up, they don't get better with antibiotics, we find a stone as the cause, they're blocked up by the stone, and until you relieve the obstruction of the stone, they have basically blocked up urine which is infected that the antibiotics really aren't getting to. So it helps me know if things aren't going well, what's going on. I also have occasional patients who drop off of urine because they feel terrible. They don't grow anything out in their urine, and then I start to say, well, maybe it's not a UTI, maybe it's not a urinary tract infection, maybe something else is going on, and those are good things to know over time before you start doling out 20, 30 courses of antibiotics over a 5 to 6 year period.
You're talking about UTI.
Yes.
Talk about hygiene.
Yes.
Baby wipes. There's so many baby wipes.
So the question is about hygiene before doing intermittent catheterization. I'm a big believer that you can do all you want and you're not going to prevent the bacteria from getting in your system. That's just me. People have done randomized control trials of absolute sterile technique for intermittent catheterization versus just clean catheterization. They've shown no difference in infection rates because I just don't, no matter how careful you are, if you're doing it 5, 6 times a day, it's just not going to be perfect. That's just life. I tell most of my patients, as long as you don't take your catheter and drag it through the mud before you put it in, I'm okay with whatever you do. If you find personally that, you know, cleaning your hands with Purell ahead of time and doing your catheterization makes you less prone to infections, I'm all for it. If you're going to spend $800 a month on gloves and other things and break your, bank account, I'm not for it. My thoughts. But I know lots of patients who say when they're very fastidious about how they do things, they do better. Go for it if it works. Just make sure it doesn't waste all your time and make sure it actually really is helping you. But those are my thoughts.
I use
Ranitidine, yes.
Solution seems to help you clear my urine kind of clear. But the thing, my question is, that's happening wrong in
Yeah, so the question is, does renocidin, which we often use for people with indwelling suprapubic tubes to prevent stones, or some people just to clean out their bladder periodically, are there any deleterious effects? My answer is none that I know of, and I sure hope there aren't, because I do prescribe it for quite a few people who have issues, especially with suprapubic tube encrustation issues where they're needing to change their tube every week to 2 weeks because of encrustation, or people have had a history of bladder stones, and I'm trying to do anything I can to prevent them from forming their stones rapidly. I don't know of any problems it can cause. The good thing about the bladder is it's covered with a layer of urothelium. Urothelium is actually pretty capable of keeping most things from absorbing. So I think as long as you're not leaving it in for, you know, days at a time, I think it's fine. It's an old solution, an old drug, and people have been using it for now 30 plus years. I would hope if it caused major problems, we'd know by now. My thoughts, I cannot guarantee it. I can't guarantee anything I do, actually, just so you know. And I never do to any patient. I never guarantee 100% success at anything.
No matter how you urinate, if I take one sample, clean up right away. So the thing is, does it work better if I just powder up the roll and then just publish it?
Wait, say that again? I'm sorry, I didn't catch the question.
And the body, grinding up with the fine powder and dissolve it in the...
Okay. So the question is bladder installations with antibiotics rather than renocidin a better idea? I don't really know the answer to that. I sometimes will do people on renocidin. Sometimes I will do them with geoirrigant, which is just neomycin and polymyxin B. Sometimes I'll do gentamicin irrigations if they have a really resistant, you know, infection in their urine. I don't know if there's any major difference. I kind of like changing it up from time to time on people just to give the bugs something else to have to jump over in terms of hurdles and resistance. But I don't know if there's any difference or any danger one way or the other. I don't love using drugs that I like to give people by mouth, because if I breed resistance using that, I don't love it. The good thing about geoirrigant is it's neomycin. It's not a drug we give to people. The good thing about gentamicin is it's really not a drug we give to people unless we do intramuscular injections or we're doing IV therapy, because gentamicin you can't take in a pill form. So I don't like to burn bridges with things that you can do by mouth, like Cipro. But is there any major danger? I don't think so.
You don't want to take it all the time.
No, and you know, the other good thing about doing bladder installations rather than taking antibiotics by mouth is you do it in your bladder, it's just working on your bladder. You're taking it by mouth, it can affect the rest of your gut flora, you can get, you know, diarrhea, other resistance. If you just put it in your bladder, the chance of breeding out resistance is a lot lower. So I think I don't have a major problem with it, to answer your question. Well, it may not work, but I don't have a problem with it. Yes, Kevin?
Dmso, does that have any antibiotic properties?
So the question is, does Dmso have any properties? None that I know of, but it makes you smell like garlic afterwards, so it must do something, but I don't have any specific recommendations. And I don't know a ton about Dmso. The only time I use Dmso is in people with interstitial cystitis, painful bladder syndrome. I will try it. I think it's a little bit hocus pocus, but it does work for certain people, and I can't discount that. It's a dimethyl sulfoxide. It's called Dmso. Yeah, no, it's just a concoction that urologists have been using for all kinds of things for years. But what it actually does, I don't really know. I'm sure Kevin could actually tell us more. He's actually smarter about this stuff than I am.
It interrupts aging.
Yeah.
So that's why athletes.
Yeah, and that's why they've used it for painful bladder syndrome. But the antibiotic properties, I don't know of any, but I've never looked at it, to be honest. Okay. Yeah, I don't know of any evidence, but you always know about stuff I don't. I have not heard anything about potassium iodide. Doesn't mean it doesn't work. I just don't know much about it. But I know that, you know, we use iodine in the operating room on people's skin when we want to prevent infection. We kind of give them a wash ahead of time. I'd be worried about iodine being a little caustic to the bladder, but I can't prove to you that might happen. I just don't know the answer.
Well, I've heard that taking it in water comes through the bladder somewhat in higher concentration into the.
Yeah, the question is putting it in water and then drinking it. Will that, you know, work? I tend to think you're going to get a lot more just overall body symptoms, and putting a bunch of salt in your body may not be the thing you want to do. I don't have specific recommendations. I'm not going to say one way or the other because I don't know the answer.
Okay, I just curious.
Not that I know of. And that's the other thing. If I don't know the answer, I'll generally tell you. I don't like to BS people. They can look it up on the internet too easily now.
I've been taking Cipro for probably 10 years, maybe 2 or 3 times a year. Should I worry about getting?
So the question is, the gentleman's been taking Cipro 2 or 3 times a year for infections for 10 years. Should he worry about resistance? I don't know. I would think the next time you have an infection, yeah, get a culture ahead of time. You'll know if your bug's Cipro resistant. If it's Cipro resistant and the Cipro makes you better, maybe you didn't need the Cipro in the first place. I don't know the answer. My guess is probably you haven't bred out resistance if you're using it that infrequently, but I can't tell you 100%. I don't know the answer. Antibiotics are always kind of a crapshoot. Yes, sir.
So you would suggest getting a test?
I generally tell people to take a test just because it's not that hard to do, and if you're not getting better, it's always nice to know why you're not getting better.
But if I'm taking Cipro and I'm getting better, then it must be working here.
I would agree with that statement. It's hard to argue.
We'll take one more question, another please here, and then we can wrap it up.
Yes, sir.
Yes, so taking antibiotics for so long, it will affect your body in some way?
So the question is, taking antibiotics all the time, can it affect your body? Of course it can, to a degree. I mean, we all have bacteria that live in our system that do good things for us. You know, they're good bacteria. They're bacteria in our gut that keep us from getting horrible diarrhea. There's bad bacteria in our gut that are killed off, or that kind of proliferate sometimes when all the good bacteria are gone, like C. difficile. You know, bacteria are not always bad, and taking antibiotics all the time, can it harm you? Sure. Will it harm you? Probably not, but it can. I mean, I've definitely seen it. So it's a loaded question. I can't give you a specific answer. I don't love my patients taking antibiotics all the time if I can find a way to keep them off it. Can I keep them off them? Sometimes yes, sometimes no. Are there people that have taken antibiotics every day of their life since their spinal cord injury and done just fine? Sure. You're going to find anecdotes of people that do fine no matter what. You know, you could feed them just Twinkies for the rest of their life, and they'll somehow be just fine. You know, they won't get fat, they won't get diabetes, they won't get cancer. But if you take the overall population and you did that, I would say it's probably a bad thing. Is it bad for one individual? Maybe, maybe not. You'll find me not super dogmatic about a lot of things.
I take a nitrocortisone daily. Would that be relevant kind of a resistance?
So the last question of the night is nitrofurantoin every day for the rest of your life. There are a few complications that can come about taking nitrofurantoin every day for the rest of your life, and I'm glad it was brought up. There's something called pulmonary fibrosis. It's been linked to nitrofurantoin for long periods of time. I don't like to keep people on the same antibiotic for more than a year in a row, even for prophylaxis like you're using it. Nitrofurantoin is a great drug because it's highly concentrated in the urine, and it doesn't affect the rest of the body very much. It doesn't affect your bowel flora. It doesn't affect other things. It's a fantastic drug, but the risk of pulmonary fibrosis is minuscule, but it's irreversible, and it can be life-threatening. So I generally tell people if they're going to take prophylactic antibiotics, take nitrofurantoin, 100 milligrams every night for a year. Then switch to Sphincter single strength every night for a year, and then go back to nitrofurantoin and just flip-flop back and forth. It decreases your chance of resistance, and it decreases the risk of these really bad side effects that you really don't want to get. If you're allergic to sulfa drugs, then do Caflex or something like that. There are a million antibiotics you can take in low-dose forms that work. You also don't want to make sure you're not taking treatment doses. The mistake a lot of doctors make was that they'll give you big-time doses. You don't need big-time doses for prophylaxis. You need very small doses because most of these drugs are highly concentrated in the urine, and that's all you're trying to do.
What was the side effect that these had?
It's called pulmonary fibrosis. Your lungs become very stiff, and they fail to open and close the way you want. So you basically die of oxygen starvation. It's bad. It's a bad disease. I never want to be personally responsible for that happening to anyone.
I think it's been taken after like 30 years.
Yep. People have been doing it. I'm not saying it's common. It happens, though, and I never wanted to be the person that was actually responsible because I do prophylactic antibiotics from time to time on people.
I go in and they take my medicine and they say, well, how long have you been taking this? They take the doctors and they say, I said, I should take it as long as I can remember. They don't take it off. They say, well, it must be good.
Yeah, so the statement is, why don't other doctors take it off? It's a little known side effect that a lot of urologists know about, but most doctors don't have any clue. And a lot of people don't want to mess with stuff that's working. I've taken one patient off nitrofurantoin that she was using for a long time, put her on Sphincter, and then she got all these UTIs for the next year, and I was miserable. And I wish I'd never taken her off her nitrofurantoin. So just so you know, urologists do things they regret too, and it doesn't always work out the way we intend it to.
Thank you, Dr. Elliott, again.
And obviously, if you guys want to come up and ask other questions, I'm here for a little bit longer.
Excellent, thank you.
Yeah, turn this off.
Thank you again for joining the webcast. You guys have a good night. It's a wrap. Thank you again.